Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. We're broadcasting live from the Dall Simons Jr. Family Broadcast Studio here at the hospital. We're delighted to be with you this morning. Welcome to Open Mics with Dr. Stites. Here you can find me every Wednesday morning talking about all things, but especially right now, talking about COVID. Today, we have several guests joining us to talk about the importance of healthcare in small communities across Kansas, which is a big concern during this COVID surge. In studio with me is Dr. Michael Kennedy, recently retired Associate Dean of KU Rural Medical Education. Hey, Michael, thanks for being back, you retired guy, you. Although he just was talking, I don't think he's very retired, as it turns out. Also joining us in the studio is Dr. Robert Moser, Dean of the KU School of Medicine in Salina, former Secretary of KDHE, and outstanding family medicine doctor. And joining us virtually is Jodi Schmidt, the Executive Director of the Care Collaborative. We're going to talk a lot about what that means in just a moment. But first, Hawkeye.
Yeah.
How did we do overnight?
You know, we are holding steady. That's not a good thing. We'd like to be going
we like
lower.
going down.
Hays went up one. They have 6 total, 2 in the ICU. I think they were at 5 and 1 in the ICU yesterday. We are still at around 36. We have 36 active patients, 16 in the ICU, 9 ventilators. So we're still having a large proportion on the ventilator. And of those 36 total patients, 4 are vaccinated. And of the 16 in the ICU, 2 are vaccinated. We are working to see if they have comorbidities. I would bet a lot of money or property or whatever I have that those people in the ICU who are fully vaccinated do have significant comorbidities as well.
Hey, and while our team brings up the most recent heat map, I want a couple of questions I wanted to pose to you, a couple of thoughts. So, kind of a big day yesterday. It feels like every day is a big day in COVID right now, but the CDC changes direction and starts recommending masking indoors for everybody, especially in high-risk areas. Clearly, we're that. We'll show you the heat map in just a moment. But then Kansas City last night announces they're going back to a mask mandate. Guys, I'm going to tell you, I'm in total agreement with that.
Yeah.
Thoughts?
Yeah, I mean, I think we have to support it at this point in time medically and from the public health. You know, it really can confuse a lot of people, the general public, lay people, just because they say, well, now I'm vaccinated, why do I have to get a mask? Why do I have to wear a mask if I'm fully vaccinated? You know, the issue is, from what we hear and understand, is that there is unpublished data which shows that vaccinated people can replicate the same amount of virus as unvaccinated people. Again, this is unpublished data that the CDC and Dr. Walensky cited. We are still waiting for that. We do know out of a smaller study out of the UK and China that if people who are infected with Delta virus can have up to 1,000 times more viral particles replicating in their upper respiratory tract. So again, we are still waiting for that. That was a small study, but that was one of the reasons, because we know and do understand from real world experience as well as benchtop and basic science research that vaccinated people prior to Delta variant really spread the disease less, had lower replication amounts for a shorter amount of time. But apparently this new unpublished data does show that you can still replicate a significant amount of virus in your upper respiratory tract, even if you are vaccinated.
Fortunately, vaccine continues to look like it protects from illness and death, or severe illness and death. But we do know from our CMO call yesterday that between 2 and 18% of patients who are hospitalized have been vaccinated. We think that it tends to be those, though, who may not be having as good a response to the vaccine. Thoughts?
You know, I think, again, the vaccine overall, just as you said, does prevent those severe disease and death. We have seen that in the real world, even in Israel and Scotland. It's been published. You know, it's unclear. These vaccines are not 100%, but they are extremely efficacious, much more efficacious than, say, influenza vaccine at preventing those things that we want to prevent, and that is mostly hospitalizations, but especially severe disease and death. We don't know the exact mechanisms. We know that a lot of people that do come into the hospital and are in those situations are immunosuppressed. There was one study that looked at vaccine and the hospitalized patients, and 50% of them were immunosuppressed for one reason or another, whether they had active chemotherapy, whether they are on immunosuppressants for, say, a solid organ transplant, or immunosuppressants for another reason as well.
Yeah, I'm going to bet we're going to see some of the same factors we knew were risk factors for doing poorly without the vaccine, which include things like diabetes, obesity, heart disease, lung disease, cancer therapy, cancer. I mean, those things are going to impact whether you had been vaccinated or not, and clearly you're better off being vaccinated. And again, remember that 80 to 90% of patients in the hospital are those who have not been vaccinated, and the overwhelming majority of deaths are those who have not been vaccinated. So there's just no question about what the right thing to do is. The other thing we have to remember is that in all those studies, and even in the Scottish data, there are still public health guidelines in place. So you were vaccinated and you had public health guidelines about masking and distancing. So we have challenged the world in a different way when we're saying to people, go out and do anything you want, and basically you're not masked and you're crowded in public spaces again, and then we go ahead and give you the vaccine. And so when we do that, we've challenged the vaccine in a way we didn't in other studies. And so I think what we're seeing is that, to your point, you still could have a lot of vaccine, a lot of viral replication in your airway, even if vaccinated. And when you're out there in a crowded situation, you're indoors, you don't have masks on, you probably are going to spread. So I think the answer is what we've always known it to be, that the rules of infection prevention and control travel with you wherever you go. They keep you safe, whether it's the Delta variant or not. And you're really safe if you're going to vaccinate and follow the rules. And I think that's what we need to do in our area because of how hot things are. And guys, can we bring that heat map up for just a minute? And there it is. Man, that map, the deep purple, is the areas that are at the highest risk around our area. And I think what you can see is it started in central Missouri, south central Missouri around Springfield, and it's continued to spread. And now it's moving east. It's clearly moved north. It's moved south down into Arkansas. It's gone west into Tulsa and Oklahoma City. And when you look at that, what you're seeing is it's traveling along highways, right? Look at the way that's going, and it's coming up north in Kansas City along, Highway 13 and 7 and our Interstate 49. It's going west along Interstate 44. It's going up in Columbia along the major thoroughfares from 44 and 54, and also up to St. Louis. This is just showing my knowledge of the maps of Missouri and along Interstate 44. So these are things we should all be concerned about, because what it tells us is we're in the highest risk areas. So all the information the CDC is saying to us is right. Wear your masks, think about distancing, get yourself vaccinated, stay safe. All right, let's see if there are any reporter questions out on the line today.
Yeah, this is Ray Daniel with KSHB 41. Good morning.
Good morning, Ray.
Good morning. Good morning. I was wondering if there was any planning work the KU hospital is doing just to get ready if you all do get crunched like we're seeing in Springfield.
Yes, there is lots of planning work going on. So, our response to the initial the prior surges, we had to reduce our elective surgery. We had to move clinics to mostly telemedicine so we didn't subject patients to risks around that. And we had to do a different staffing pattern, both within our medical staff and our support staff, nursing staff, et cetera. And we've got all those things ready to roll out if we get to the point. And I think, in our conversations yesterday in our CMO call, I think everybody's got those same plans ready to go, because the difference between now and before is we really don't have a lot of capacity. So there's not a lot of room, and we're having to turn down a lot of transfers from COVID-19 as well as non-COVID-19 related illnesses. So what that means is this. If this was last fall and we had a few more open beds to play with, then we would be accepting more patients from the outside. Our COVID-19 numbers would be higher than they are today. I'm glad we've stabilized around 60, and 35 to 40 acutes. But I'm concerned that that's not the end of the wave, that this semi-crest we've seen, where we've been about the same number for about 7 to 10 days, that's good that it's not going higher, but my fear is we're seeing an increasing number of positive patients in our metropolitan area, and then in 2 weeks this surge is going to take off from the plateau and go to the next plateau. That's the time we're going to be the most nervous, and that's when I think we're going to have to be looking even more carefully. Right now, we haven't had to cancel in elective surgeries. Our goal is to not do that, because when we do that, we're really triaging care to some patients, right? Because those elective surgeries often aren't really elective. It's, the person who needs their hip replacement because of severe pain, delaying a cancer surgery, having a sinus surgery that you have to have because of chronic sinusitis. I mean, these are things that could, if you're the patient, they're really difficult. You don't want to have to delay those surgeries. And so far we haven't, but I think we stand ready to if the situation in our city deteriorates further, which, by the way, is one of the reasons we're pushing so hard to get back to getting the public to masking and social distancing, because we know that will bend the curve. And we honestly know that if we could do those things and vaccinate everyone, not only would we bend the curve, we would break the curve. And man, I'd love to see a broken COVID curve. Other questions?
Dr. Stites, I have one from Channel 9.
Okay.
Okay, so this is in preparation for the possible announcement of a mask mandate for vaccinated people today. They want to know, how many total ICU beds do we have here at the health system, and do we know how many of those are being occupied right now?
Okay. Off the top of my head, I'm not sure I can give you the numbers. I want to. We have more than 100 ICU beds. I don't remember the exact number right now, and most of our ICU beds are occupied because our overall census is so high. And so what tends to happen is that when we have a lot of patients in the hospital, when you get stabilized in the ICU and you can move to the floor, we can't move to the floor because there's no bed on the floor to move to. So that's actually one of the reflex we have. We try and get some folks discharged. That allows us to move people out of the ICU, which allows us to put more people up in the ICU. Let me come back with a more thorough analysis tomorrow than just those words, and Hawkeye and I can tackle that question.
Do we know how many people with COVID are in ICU beds?
We do.
Yeah, that was 16 patients, 16 total in our ICU beds. 2 of those 16 are vaccinated.
And how many were on ventilators today?
9 were on ventilators, so
which is actually down a little bit, so that's good.
The number, yeah.
Yeah.
And just last question, just comment on this. Is the ICU unit here at the hospital in danger of being overrun by people with the Delta variant or any type of COVID?
Yeah, overrun's a strong verb there. I'm not sure I would say overrun. I think we're challenged by it. I think that, again, we've hit a plateau. We've been on this plateau for the last 7 to 10 days, and that's good. The plateau's higher than we'd like, but it's not at 125 patients when we have 125 acutes and 125 recovering, 250. That, you know what? That'd be really hard because we're so full otherwise, and all the hospitals in Kansas City are so full. So where we are today, we can manage. The question is the following. You saw that heat map. Is this our crest and we're going to start going down? Or is this just a plateau and we're going to expect to see another crest that'll be higher than this? We don't know the answer to that, but that answer will dictate what our response is, which is why we are trying to push so hard on getting people to mask and distance again and get vaccinated, because we know that's how we can prevent that curve from going higher. Remember how we used to talk about bend the curve? That's why we're pushing it. Bend the curve, and gosh darn it, if you really get 85% of people vaccinated and you get everybody wearing a mask and socially distancing, we will break the curve, and the numbers will go back down to 2. Which is where we want it to be, because then we can take care of everybody no matter what. And right now, our way of controlling the number of inpatients is really, because we can't control it when folks get to the ER, and this is true throughout the city, throughout any city, it's true in Springfield, which they, by the way, there's an article I read yesterday they were talking about, they're still at the same high plateau, though things haven't gotten better in Springfield. And the problem is that they're having trouble transferring patients out. We can't take transfers. We take very few transfers right now, whether you're COVID or not COVID. And that's our way of controlling the ICU population at the moment, and that we're doing.
And I have a little bit of information too about our ICU. So we do have 2 ICUs now that have the COVID patients, and those vaccinated people that are in the ICU. Again, 2 out of 13. One has lymphoma and lung fibrosis, and another one is quite a bit older, over 90, and has significant heart failure as well. So obviously significant comorbidities.
And people who probably didn't respond well to the vaccination. Yeah. Again, if you have a good vaccine response, we're just not seeing folks like that getting critically ill. Was there another question?
Hi.
Go ahead.
Yeah, it's Carolina with KCTV5.
Yep.
So you've been mentioning how this is the pandemic of the unvaccinated, but following the CDC's guidance yesterday and then Kansas City's semi-announcement last night, I did see on social media some people who have been masking, who have gotten vaccinated, who have been trying to be safe, expressing some frustration because they've been doing the right things, and then now it's kind of reverting. What do you say to those folks?
Hang in there. And then I would say this. It is very easy to be frustrated that folks have not been vaccinated, and that because of that, we're having another wave and we all have to go back to social distancing. You know what? That's frustrating. But the reality is that and this is Steve Stites, individual citizen, not speaking for the health system now because I'm trying to do a political lesson, which is always dangerous. But I think that democracy is an interesting beast, right? Because we do get the ability to make choices. And there are good things in democracy, and there are things that are sometimes a struggle. What I would urge our listening audience to remember is this. The preamble of the Constitution does not start with the words, I the one. It starts with the words, we the people, in order to form a more perfect union. And it talks about justice and protect provide for the common defense, promote the general welfare, and secure the blessings of liberty. We the people means freedom with responsibility. So what I would urge us all to do is remember that freedom and responsibility also means we have to take care of each other. So yes, we can be very frustrated as a vaccinated person with those who were not vaccinated. But we're all in it together at the end of the day. And instead of being angry, let's be persuasive. Let's talk and have a good, honest conversation. Here's what you have to encourage people to do. Stop listening to the made-up news network. Don't be a munz. Don't be a rumor reporter. Because if you just listen to the truth, and we tell it to you every single day, you will recognize that which you read on the internet is frequently just not true. That things like the New England Journal of Medicine, things like this media update, where we try every morning to just tell you the best truth that we know at that moment. And yeah, we've been building the airplane while we fly it, but we constantly, we're just transparent, we're just telling you the way it is. So we the people, does that result in anger or persuasion? Here's what I think. Anger will just make people dig in deeper. Persuasion and honesty, that'll win the day. So let's follow that road instead of the road of anger. Because anger, what's that? Anger leads to hate. Hate leads to, what is that thing from The Force? That's just not good, right? That's Star Wars. I've not made a Star Trek reference today. I will, but don't let anger lead to hate.
And I think we've seen throughout history, coercion really doesn't work.
Coercion doesn't work. So let's try to be persuasive. Let's continue to tell our story. And let's remind people that we're all in this together. That really is we the people.
And then
Really
I did
quickly,
have a follow-up.
I'm so sorry. Go ahead.
I saw CNN just pushed out saying that new data released today shows that a third dose of Pfizer's COVID-19 vaccine strongly boosts that protection against the Delta variant. Have you guys seen anything on that yet?
Yeah, there's been a lot of information pointing toward that third dose, and I think Pfizer has kind of pushed that. Obviously, that's been true in Israel. I know the CDC is hearing the information. It's interesting because when you look at other stuff, if you look at the real-world data, the two doses look pretty darn effective. Mm-hmm. The question is, are there going to be populations of patients in whom a third dose will work? My gut feeling is we're going to end up doing a third dose, especially maybe for everybody, but certainly in select populations of more highly susceptible and critically ill or chronically ill patients. But I'm going to wait on the CDC to give us and the FDA to give that final analysis. But I bet we're going to land there. What do you think?
Yeah, I think we've always anticipated needing some sort of additional dosing, whether it's a booster made on a pivoted spike protein, maybe from Delta variant, or we know Moderna was looking at the South African variant spike protein to put into a new vaccine. It's unclear exactly what this means. I'd certainly like to look through it. Doesn't mean it's increasing your antibody levels. Again, we know natural immunity. We know that your antibody levels wane, but you have the fortunate process of those B cells, which are still circulating, which can be called into action very quickly when you see the infection again to create more antibodies. You have those memory T cells, which are there to help address any new infections as well. So we'll see what that means. Does it help clinically? I think we'd like to see that as well. Will it be beneficial? But of course, I don't see any harm of giving additional dosing. So we'll kind of wait for the full impact of that and the data review and kind of see what the CDC and FDA think is reasonable to do. But overall, again, we know that these vaccines are safe. Additional dosing with these mRNA vaccines is really not going to be harmful at all. So if it provides more protection, especially as you said, maybe to some of those older age group where there's some immune senescence or the immune system isn't functioning as properly, or some of those other immunosuppressed populations, it could certainly be a benefit.
Yeah, I think it may. And then I think when they reconfigure it with the mRNA a little against the alpha or the delta variant or whatever other variants out there, I think that may impact things. Let's get to other reporter questions.
Two really quick questions. This is Ray Daniel again.
Hey, Ray.
You know, one of them is if you are in a room full of fully vaccinated people, do you recommend putting the masks back on? Do you not recommend that? And then to piggyback off of that question, you know, for people who are traveling, do you recommend they reschedule travel plans? What are your thoughts on that, doctors?
So on the traveling question, here's what I think we can say. COVID is everywhere, so the key isn't whether you travel or where you go, because you could get it at the grocery store, or you could take it if I go to St. Louis or Colorado or the woods. I think the real question is, how are you conducting yourself when you go? And I think if you're willing to put on your mask and make sure you're vaccinated, that's the best you can do no matter where you are. Now, folks may argue and they may say, gosh darn it, but Kansas City, and you guys are at the epicenter, you're just going to export Delta variant, but I think the Delta variant is 87% of the cases in the U.S. right now. It may be 98% here, but I don't think that's a meaningful difference. And so I think the reality is that I'm not sure travel is going to be super impactful. And I think airplanes have been, I think people have worked hard to keep airplanes safer. The negative airflow inside the airplane has really been pretty effective. We'll have to wait and see how the Delta virus, because it's so much more transmissible, that story may shift a little bit. But if you've got your mask on and you're in a plane, I think you're okay. I think in the airport, you just got to keep your mask on. I mean, at the end of the day, if you keep your mask on, things are a lot better off. So I think, to me, that's the key. Hawk, what do you think about that?
Yeah, I mean, I totally agree with that. I flew recently, luckily with the FAA or other federal guidelines, you still need to be masked. I certainly wore air protection, eye protection. I think that is important. You know, understand where you're going. Still be wary of those indoor spaces, but I think you can make traveling as safe as possible if you do those couple simple things, and that is masking, eye protection, hand hygiene. I think it can be safe as possible.
Yeah,
I would really encourage you to look at where you're going. I would be a little bit hesitant about international travel at this point, just more for the fact of, can I get back into the country? If I happen to be positive, now do I have to wait 10 days or 14 days?
Right,
So
or get medical care
getting
outside
back
the
in.
United States.
Yeah.
And yeah, I think that might be a challenge, and I'm with you about that. And just the original, the first part of the question was, are you safe if everybody's vaccinated to take your mask off? And I think that's a personal calculation.
Yeah.
I'm going to a dinner tonight with some folks, and I know everybody's vaccinated, and I think I'll probably have my mask off while I eat and talking. But in general, I do like to know if people are vaccinated. My sense is that that's safer. But I think I'll probably go back to the rules where we were, which is that, in general, we're going to be sitting a little further apart at the table. I'll wear a mask into the restaurant. I'll take it off to eat, and I'll put the mask back on as I exit the restaurant, which is really the behaviors we had back when we had an inpatient census of 2. And gosh darn it, I'd like 2 a whole lot better than 30. All right. Let's move to the next part of our program. We're going to keep talking COVID for a few more minutes. So since March of 2020, we have been focused on providing support to healthcare providers across Kansas in response to the pandemic. One effective tool was the University of Kansas Healthcare Collaborative, which was up and operational. The Care Collaborative is a clinical network connecting 76 partners in 65 out of 105 counties across Kansas. It began as the Heart and Stroke Collaborative and has grown to include many more health conditions. I'm guessing COVID was not on that original list. Still, the Care Collaborative moved into action. I'm going to first turn to Jodi Schmidt, the Executive Director of the Care Collaborative. Jodi, tell us how the focus of this network changed with the onset of COVID. What kinds of support has the network provided, and is the need still there?
We absolutely made a very quick pivot from the work that we were doing. In fact, we were getting ready to launch a program around trauma in rural communities, and instead made that shift to provide the same sorts of evidence-based practice and academic resources to our rural communities that we have for heart attack, stroke, sepsis, and other conditions. To do that, it did mean that we were taking the rapidly changing research that our team in Kansas City was reviewing continuously, creating best practices and protocols and policies. Then Dr. Moser and our clinical team translated those into the right recommendations for a rural environment, and we got those out as quickly as we could. To date, we've provided more than 100 resources to our members. Similarly, the move to telehealth as a result of the pandemic exacerbated the broadband gaps across our state. So we moved very quickly, working with the Department of Commerce, and achieved a $3 million federal grant to bring additional support to our communities, to connect rural health clinics with their patients, to connect hospitals with their testing and vaccination sites, to connect with EMS and long-term care. And we also piloted remote patient monitoring in 250 very high-risk rural patient homes so that we could track how they were doing locally, both post-COVID and because of multiple chronic conditions that put them at high risk. Lastly, we brought in an expanded version of a program we've had for several years in the Care Collaborative, Mission Control. It was designed to allow facilities to connect with air ambulance providers without making multiple phone calls. Well, when the pandemic hit, and particularly at its peak in late fall, early winter, facilities were needing to call 8, 9, 10 facilities trying to find an available bed. And so we asked our partner to add that bed finder capability. It worked so well that KDHE adopted it for statewide implementation. And it allowed our rural providers to focus locally on what was going on with their patient in front of them, not having to spend all of that time on the back end trying to find an available COVID bed for those patients who needed that next level of care. It's been an ongoing commitment that we are continuing. We're expanding our remote patient monitoring to the next group of patients who have multiple chronic conditions and continue to be at risk. We're continuing to share the research like we heard again this morning. It's a continual process of sharing the latest information and best practice recommendations. And we're also exploring as a team what's really working in rural vaccination methodology. What can we share with our members that can help them improve the vaccination rates in their communities?
Thank you very much. And that, first of all, what great work that the Care Collaborative has been able to do. Dr. Moser, the learning curve has been steep with this pandemic. How has the collaborative helped?
Yeah, as Jodi mentioned, I think was really just already having a connection with a number of our rural practices and a partnership with the Kansas our Hospital Association. So we teamed up with them to get on a regular call that ended up becoming basically weekly to be able to kind of share some of the resources that were being developed up here at the University of Kansas Health System and putting those into best practices. And it was a little bit of a challenge because of the way COVID rolled out across Kansas. It was mostly in the metropolitan areas to begin with, but once it began to hit into our communities where we had the meatpacking plants and others across southwest Kansas, it really did explode, as you obviously can relate to and remember. And leading into that huge surge in November, where, as Jodi mentioned, the biggest challenge was just finding places where these patients could go that needed more advanced care. So I was very proud of the way that our county health officers across the state, our rural providers, and their care teams really ramped up their response to dealing with what they had to in their communities with limited resources. They were very aggressive about being some of the first programs to utilize the monoclonal antibody. And so we took, obviously, the infusion recommendations from here and adapted them to the rural centers, and they quickly took it upon themselves to make that available to their patients. So it's really a great effort, and I know they're tired. I know they're probably frustrated with what they're seeing with the low vaccination rates, but they continue to do a great job out there, and we're seeing some communities doing a great job with that, and we hope to share those best practices.
Dr. Kennedy, early on in the pandemic, residents were brought into the equation to provide clinical support. How did that help, and how did the resident trainees, how did they react?
So it was actually very extraordinary. Their response was amazing. We had a varying amount of need across the state. The hot spots in southeast and southwest Kansas is where the majority of the recent graduates and they would like to call themselves residents at that point, but they weren't quite there yet. Most of them had matched. But they...
so they're really fourth-year students, and they may have been graduated from being a fourth-year student and started residence, so they were sort of like...
they were in between.
They were nomads or something.
Yeah, exactly. Yeah. So they... they just stepped up to the plate. It was extraordinary. It brought tears to my eyes, their response. They are so dedicated, and they were so energized by their ability to help in some of these systems. And I think that brought an energy to the care teams that were starting to get to a burnout point, you know. And so you have these fresh faces come in. They came in, they really helped in terms of patient care, but they also helped in the clinic in offloading some of those other duties that physicians could then turn to those sickest patients to care for them. So it was an extraordinary response. I had them all write a reflection paper after their experience, and overwhelmingly they were appreciative, they were humbled, and you know, those I got to figure out something to do with those papers because it's a heartwarming story, to say the least.
Yeah, it is a heartwarming story. And just to say, folks, I'm going to just go off script for a moment. I know that never happens to the team in the studio who tries to follow me, but Bob Moser and Jodi Schmidt and Michael Kennedy, you all represent some of the best that Kansas has to offer. The work that you guys have done in this is really tremendous. And Dr. Kennedy, you recently retired. So before joining our health system, and I'm very jealous of that, by the way. In fact, before the program, I was asking, so how old were you? How much longer? Before joining our health system in 2002, you spent a decade in private practice in Burlington, Kansas. You were responsible for all medical student placements in rural education for the Kansas City campus. What are some common challenges when it comes to rural medicine?
Well, I think, you know, probably the biggest challenge overall is keeping health systems viable financially as payment models have changed over the past 20, 25 years. Okay, 30 to 40 years.
Longer.
And then also trying to keep student interest up when it comes to wanting to practice rural medicine. You know, you have to fight things like professional isolationism. You have to fight some of the common myths that are out there, that it's not as challenging or it's not as rewarding as an academic medical practice, which is total bunk. And some of our most talented physicians have chosen rural careers. So what I've tried to do over those years since 2002 was to really show students what a great practice opportunity this can be for them, that it's intellectually challenging, that it's tremendously rewarding. And then and the way to do that is to get them out there and get them out into rural places with those docs that are on the positive side of the curve, really doing well in their practices and doing well managing the challenges of a rural medicine practice.
So role models always make a difference. Bob Moser, you were a rural physician as well before you decided to move to this major political career, Secretary of Kansas Department of Health and Environment, and now a Dean of the School of Medicine in Salina. talk to us a little bit about some of what Michael just said and your thoughts about this rural healthcare.
Yeah, I agree with Mike completely. The biggest challenge, we need to feed the pipeline. We've got to get more students interested in healthcare as a career. And obviously we know from the data over 40 years of study that if you grow up rural, you're more likely to go back rural, you're more likely to practice primary care. And we've seen kind of a drop in the number of students from rural Kansas applying to medical school over the few years. And so we'd really like to reverse that and start increasing that. But we also, I think from the Care Collaborative, Jodi and I have definitely found benefits of having a larger health system and other resources to bring in to kind of help those practices keep up and adapt to all of these new changes, these new models of payment, these new requirements for quality reporting. It's tough to do. There's just not that many bodies out there or that much expertise in a rural setting. So getting access to someone and a system to kind of help out to move that forward, I think, is very important. It takes a lot of work off of the providers. They're head down. They're working as hard as they can. They don't need one more things to do. So having that outside resource to tap into when they need it, I think, is really important.
So I'm going to ask you all this question before we move to Jess, and we're just going to ask you about the future of rural medicine. Each of you, I'd like to hear from you. But what are some of the improvements that are you seeing, and what does the future look like in rural healthcare? Jodi, let's start with you.
I'm actually very excited about the future of rural healthcare. If you think about where we're going as a country, rural healthcare really already encapsulates it in terms of really working with a panel of patients to improve their health. In fact, recently we had 2 chief medical officers from New York City and New Jersey out touring in some of our rural communities, and they commented that these rural physicians were really enjoying their work, and they really understood their patients and had a long-term relationship with their patients, and it was clearly showing in how well the patients were doing and how connected they were. And then we have some new models like the rural emergency hospital model. I've been around at this for more years than I'd like to count, more than 30, and I was around when the first critical access hospitals became that designation here in Kansas. I helped many of them make that change, and this new program is that next step, that glide path to help rural hospitals make that transition so they can focus on outpatient care and emergency room care and home health and complex care management and the type of work that we've been piloting in the Care Collaborative. So while there are absolutely challenges, and those challenges have remained the same in my more than 30 years in rural healthcare, but I truly do believe that we see some exciting new developments, and I'm very proud to say that the Care Collaborative is doing all we can to provide additional resources to make that just a little bit easier.
Yeah, that is so true. Okay, Michael, what are your thoughts?
So I really.
You're about to say you're stoked because you're such a good guy. Such a young
I'm
guy
stoked. I retired at the wrong time. The students recently there's been an uptick in interest, and so the students that are applying, and so Dr. Moser was right, we had kind of a dip, but now we're on the rise, and the students that are coming in are so altruistic, and they're so mission-oriented, and they're so driven, and they talk about long-term relationships with patients, that this is what they want. They want to know their patient in the context of their community. They want the village effect of small rural America, and they're just all charged up. And so, of course, that gets me all energized. And so working with them has been a tremendous reward. But I think they also have the benefit of some of the things that Jodi was talking about. They have the benefit of new technologies that are emerging in terms of point of care access to resources, and maybe even point of care access to referrals, so that while they're in the process of decision making in the emergency room, then they can access some help with those decisions if needed. One of the things that I still remain concerned about, though, is access to maternity care. And since that has not proven to be a profit center for a lot of hospitals, rural hospitals, and there are some challenges there in terms of maintaining the complex structure of people needed to provide good maternity care and delivery services, then paying for the people to be on call, maintaining that structure that for delivering 70 to 100 babies a year. I don't know if that's going to be profitable for the future. And so then what are we going to do so that women don't have to drive an hour and a half to 2 hours once they go into labor to deliver a baby?
Dr. Moser.
Yeah, I just add to, I think, a couple of things that Jodi and Mike said. And back on what's happened with COVID, we had contemplated introducing telemedicine as part of the curriculum in medical school, and looking at the expansion of telehealth and telemedicine across rural Kansas. And all of a sudden with COVID, we had to obviously implement a lot of that, and I know they did here as well at the health system. So I think telehealth is really going to play an important role in providing access to health care, including specialty care, as Mike pointed out. That just-in-time curbside consult is something I've always talked about to Jodi and others, that we used to do it by phone with folks that we had already developed relationships with, and we'd often present a case briefly, learn how to manage that, and then identify when we needed to move them up the road. I think now we've got telemedicine available. We can help with some of the transportation access issues that Mike points out. But there are some things that, as he pointed out, that we need hands-on, the training at the level to manage those complex cases when they hit the door, like delivering a baby. We like to think that that's simple, but it doesn't always, prove to be that way 100% of the time. And I think the biggest challenge is going to be around the transportation, but particularly around emergency medical transport. It's still considered kind of a 911 type transport system in Kansas, and we're too big and broad of a rural state to just have that as the sole focus. We need to be moving patients from our primary care centers up to more tertiary quaternary care centers, and it doesn't make sense to have a secondary type movement transport company do that. That's part of the hospital. It needs to be part of the system as a whole. So a lot of systems of care, I think, are going to continue to be developed as a result of what's happened with COVID and what's happening with the marketplace in general. So I'm excited too. I'm like Mike, terribly excited with the ambitions and the altruism that we see in our medical students going forward, and I think we're in good hands.
Yeah, I'm reminded a little bit about Reagan saying to Mr. Gorbachev, tear down those walls. I think telemedicine has helped tear down those walls to the rural communities. Jess, I know we spent a lot of time on questions, and we had a lot of reporter questions. Where are we now with our listening audience?
Okay, so we've got some good questions, and Bob has a good one. Rural communities traditionally put a lot of faith in their town doctor and follow their advice. Is that happening with COVID and the vaccinations? And if not, why not?
Boy, that's a great question, Bob Moser. I know that's got to be something near and dear to your heart.
Yeah, it is. I personally had great relationships with my patients, my community. I'd like to say they always listen to my advice. Obviously, with a lot of preventive health recommendations, we would talk about wearing a helmet when you rode a bike or a motorcycle, wearing your seatbelt when you're in your car. And I had to fight with people about, well, I had an aunt who, if they wouldn't have had their seatbelt on, they would have lived in their car wreck and whatnot. And we have to, point out, well, take it in the general context. In the large population studies, we know seatbelts save lives. So it may not be perfect in every case, just like vaccines may have some side effects, but overall, they can save your lives and they can protect others. So that's the messaging that we're hearing a lot of our rural physicians, put out. And I know they've been kind of frustrated with the way some of the policies have come out from on high. All the way down to the local level, but they're still going to work every day. They're still having these conversations with their community and their patients. And I think in some places we're seeing, higher rates of vaccination in small rural communities than in others. And so, as Jodi mentioned, we're working with them to find out what are those best practices. How can we move that out across? So I think it is better, but it's still a challenge.
Yeah, I bet it is a big challenge. Jess, other questions?
Yeah, Isaac wants to know, what has been COVID's impact on rural hospitals in terms of financial losses and number of facilities that have closed? Is it true that before COVID hit, some of these Midwest hospitals were struggling as it is?
Jodi, you know that area extremely well, and it has been a challenge.
It has been. Our rural hospitals have been challenged over the last decade. COVID did provide some short-term funding to help them manage the pandemic successfully, but those funds are not going to be able to sustain them long-term. And that's why it becomes so important for those local hospitals to continue to meet the needs of their local patients so that they keep as many patients as close to home as possible, so that they really are identifying the needs of their community and meeting them again, because that's important to them both from a community support standpoint, but also from a financial standpoint. I will say that, over the last decade, more than 100 rural hospitals have closed, and we have had a few here in Kansas as well. Unfortunately, the most recent data suggests that we are among the top 3 in the nation in terms of hospitals considered at risk. We're fortunate that Kansas taxpayers have stepped up to support their local hospitals as best they can, but it isn't always enough. And that's where we're exploring other kinds of programs to help them transition from a hospital as they currently are today to a new type of facility that really does meet the physical therapy and respiratory therapy and emergency room needs of their local community and provides expanded home health and expanded telemedicine and good solid transportation systems. But perhaps not every community will be able to sustain their inpatient beds. And if there is that kind of a change, then what do we need to do systematically as a state to support those communities and those patients? So there's some exciting new telehealth programs like Hospital at Home that we're exploring. And the work we've done in remote patient monitoring, we have some wonderful patient stories where we've been able to catch a patient early in decline because we've been monitoring their pulse oximetry, for example, and been able to get them right into a physician right away. There's more and more we can do, but it's not just about the technology. It's about having a whole set of services along with that technology to really make sure that the people are engaged in the work. We've had some, as I said, some great patient stories. A patient just last week reached out and said, with all of the support I'm getting, I'm now able to get up and down out of my church pew on my own. And those are the sorts of things that we're able to help people really understand about their chronic conditions, their heart failure, their COPD, their diabetes, where we can help them make good choices and be able to stay in their rural communities with the right sort of support. I do believe more and more telehealth will be critical to that long-term success of our rural communities.
Jess.
Dr. Stites, I just want to get to a few COVID questions. I know we're
Please.
tight on time, and then we'll save the rest for follow-up Friday. Anil has a question. He says that he heard a particular, shall I say, political figure state repeatedly that the Delta variant is less lethal and less dangerous. Is there any truth to that, or are we just getting better at keeping people alive?
Oh, that's a great question. Was that our Anil Garmarker who asked that question? Okay, Anil. I hope you're on the road to recover and stay on it, brother. We always think about you and pray for you. Hawkeye. Yeah. It is not less. It's certainly not better than the original strain or the Alpha variant. Because it's so transmissible, it's more dangerous, not less dangerous.
Yeah, I don't know that we have any data to suggest that it causes less severe disease or is less dangerous at all. I don't believe any of that is supported by the research evidence at this point.
Yeah, I would say to you that because it is so transmissible, it makes it more dangerous. But in terms of once you get it, do you get sicker or die more frequently? I don't think that's the case. I think it's going to be similar to the other variants we've already seen.
Meg says, I'm confused. My husband and I are fully vaccinated. Should we be wearing masks around our grandchildren who are not vaccinated?
Oh, gosh, that's a great question. Okay, we'll both take a little swing at this, and I'll take any advice from our panel. So, it's easy to be confused on this question because it's confusing.
Yeah.
So remember the CDC said, look, you've been vaccinated, you don't need to wear a mask. Go out and be normal. And now the CDC is saying, hey, gosh, you've been vaccinated, still wear a mask. So why did they change? They changed because the Delta variant is so much more transmissible, number one. And number two, because we're seeing the rise of the Delta variant so rapidly throughout the country. Number three, there are so many unvaccinated people. So what we are really doing is saying, we the people, if you've been vaccinated, you can still transmit disease. If you can transmit disease and there are a lot of unvaccinated people, they're going to get it. And so in addition to that, we know that if you've been vaccinated, even though you probably are not going to get very sick, you can still get sick. And in addition to that, as a vaccinated person, if you're going to be around someone who is chronically ill, who has been vaccinated, for example, but let's say they have heart disease, they've had a history of chemotherapy or what have you, in other words, they're one of our typical elderly patients, their ability, how well that vaccine worked in them and how well it's going to sustain isn't as clear. And so what we're saying is, just to be safe, if you're vaccinated, you still need to wear a mask because of the Delta variant out in the public, and that way we're protecting each other. If we get more people vaccinated, we think that that's going to go away. But we've got to get more folks vaccinated. So I think the long-winded answer to this question is, the change that has happened is that we don't have enough folks vaccinated, and the Delta variant is so transmissible, and so we're asking everybody to mask, even those who have been vaccinated, which I get, look, that's a bummer, right? No one wants to go back to doing that. But as we also said yesterday, wearing a mask is still a very simple act of faith and a very simple act of love. And so even though it's painful, we have to go back to it, I would urge all of us to do that until we get more people vaccinated, and let's continue to try to persuade those who are unvaccinated to stop listening to the made-up news network.
Yeah, and I think we should emphasize, the exact wording, and this is wear a mask in public indoor settings if they're in an area of substantial transmission. The other component to that, particularly for this question, again, for the exact wording of the guidance, is that fully vaccinated people might choose to mask regardless of the level of transmission, particularly if they or someone in their household is immunocompromised or at increased risk of severe disease, or if someone in their household is unvaccinated. Again, at that point, you may choose to do that. The guidance really is focusing on those public indoor settings. At this point in time, it goes back to what Dr. Stites and I have talked about in the past, assessing that risk for you, but as well as for those people that you are interacting with.
Jess?
Question. We're talking a lot about masking, but Janet wants to know, what role does social distancing play in all of this?
Man, I think social distancing plays the same role it did at the beginning, Hawk.
Yeah, I think it absolutely does. Again, I was recently out on vacation, was at a beach. I felt fully safe. I wasn't in indoor settings. I think social distancing, along with the masking, and then again, adequate, frequent hand hygiene is important. All of those things are part of that Swiss cheese model that we have heard about since the beginning of the pandemic, in addition to vaccination. But to short answer to the question, I believe social distancing or physical distancing continues to be a very important part of this.
Jess, last question.
Oh, okay. Well, this is fun. Do you think that Arrowhead will have to reduce its capacity this year? What are your thoughts? Don't give us the bad news yet.
No, I don't know yet. We're not going to go there because it's not fall. We can still get more people vaccinated, and we're going to watch and see what the trends do. So I'm not going to go there yet. I'm just going to say I want to go to Arrowhead, and I want to be among 78,000 people screaming at the Chiefs to win and carrying that team. So I think it's too early, Hawk.
I think it's too early. I think we still have time to continue to push and encourage vaccination for everybody.
And just to say, at the Royals games, we talked to the county health department yesterday for our city, Jackson County, or Kansas City, Missouri, Rex Archer's office, and they felt like they weren't seeing a lot of transmission at the Royals games. So that's a good sign. All right, final thoughts from our guest today. Jodi, I'm going to start with you.
Well, we certainly have ongoing challenges, and we recognize that what happens in the Kansas City area may spread to our more rural communities. So we're doing all we can to continue to support our rural communities and help them prepare should the Delta variant continue to grow. Most of our members are showing a small increase at this point in time, but certainly we'll continue to be vigilant and continue to share the resources of our academic medical center with all of those across the state.
Outstanding. Michael Kennedy.
Our youth is our future. So the students and the trainees, this new group is excited and energized and up to the challenge. And so I'm very optimistic about who's going to be my doctor as the years go on.
Outstanding. Dr. Bob.
Well, I'd just like to take the opportunity to say thanks and God bless to all of our healthcare workers across rural Kansas, from administration down to maintenance folks, for what you do each and every day in providing healthcare for our rural communities across Kansas. And hang in there. I know the COVID pandemic has been tough, and it will remain so until we get more folks vaccinated. And just to listen to the CDC guidelines. They're correct.
They are correct. Doc Hawk?
Yeah, I know there's been a lot of frustration with throughout the pandemic, but especially now as there's some walking back or some reversible or pivoting on some of these mask guidance. It is important. We do this on a daily basis. We get frustrated at the situation as a whole, but we continue to do it and continue to work with compassion, hoping to continue to give our message and the correct message, the correct medical and public health guidance messages to you to make it more clear. Stay with us, keep your head up, and continue to encourage vaccination as much as possible. We'll be right there with you.
Deep breath. Hey, thanks for being with us today. Tomorrow I'll be back on the Morning Medical Update with Jess. Tomorrow we have details on a free MCA cancer screening coming up. We'll keep following this surge, including new masking guidelines. My last thing I want to say today, my final words are, the reason I love Star Trek: live long and prosper. Why is that? Because that is a symbol of hope, optimism, and faith. We can be mad and frustrated with each other about not being vaccinated, but remember, we the people means we're in it together. Let's persuade, not be angry. We'll be back tomorrow. We'll be telling more of the truth to help you live long and prosper. See you then.